Hello, folks. Looks like it is 1 o'clock, so I will go ahead and begin the introductions and welcome you all to Grand Rounds for Psychiatry. So first, I'd like to, before I introduce Dr. McClain and Adrien Lawyer, I would like to welcome you all and open with a reminder of why this is important. So identity is important to who we are as individuals and as unique human beings. Learning about our patients' identities is foundational to the clinician-patient relationship. We have an obligation to role model respectful patient care and support our patients with advocacy. So I'm excited to announce this presentation about transgender clinical inclusion and to introduce Dr. Molly McClain and Adrien Lawyer, our presenters. I'd also like to share that Dr. Cameron Crandall is joining us from the HSC Office of Diversity. So Dr. McClain, she graduated from our own Family Medicine Residency here at UNM. And since that time, she's been working with gender expansive people of all ages. She started the first all ages gender clinic in New Mexico. And she's the medical director of Gender Care for New Mexico ECHO and the program director for the Family Medicine Residency program as well. Adrien Lawyer co-founded the Transgender, just adjust here, Resource Center of New Mexico in 2008 with Zane Stephens to be a clearinghouse of direct services, education, and advocacy for the transgender community. Adrien has delivered transgender cultural fluency trainings in thousands of settings. It's really impressive, all of the settings that you do this work. He has led successful advocacy efforts to model transgender policies, restrooms, inclusions, bullying prevention, and birth certificate changes. So without too much further ado, I'd like to turn things over to Dr. McClain and Adrien Lawyer. Thank you for joining us.
Thanks so much. I'm going to be sharing my screen and running the slides. There's always the concern about with me personally, technical snafus, but once I get that started, Adrien's going to start us off. Oh, this is new. Portion of screen. Yep. All right. One of the bummers about this setup is that it's hard for me to see the chat, but we'll do our best to keep up with that. Are folks able to see my full slide?
Mm-hmm.
Great. Okay. Take it away, Adrien.
I can see the chat also pretty great.
So. Oh, lovely. Yeah. Perfect.
I'm an attendee right now, so I'm really in the chat right now. Okay. In fact, I just dropped a whole bunch of stuff in the chat for y'all, including my contact information and some other really important links from TGRC's Ed department. I don't mean to be this kind of performer. And certainly we're so excited to get any amount of time with y'all to talk to you today. But our trainings we consider to be a 2-hour minimum usually to get really what you need to get out of it. So there's my cell phone number and email address if y'all are interested in any further educational collaboration. We would just love to do more with you. The more you learn about anything like this, the better you'll do with this group for sure. Trans clinical inclusion, here we go. Okay, so did you go? Okay, good. Okay, this is just about the center, and this is the hardest thing in the training for me is to keep this under a couple of minutes because I like to talk about the center for 15 and 20 minutes at a time, but I'm going to stall a little bit and give some highlights while I try to let you skim this and read it. Everything that we do is on our website, on our social media. You can text me, call me, or email me, and I can fill you in on anything we do. But essentially, we do this huge array of services for trans and non-binary people. The stuff in the middle of the screen is very specifically things that we can do for anyone, anywhere in the state. We are not just nominally a statewide organization. We are a statewide organization in practice. We do about $8,000 a month in direct financial assistance to trans and non-binary people all over New Mexico. We can help with legal name changes. Our 8 support groups meet on Zoom and also have Google groups and Discord servers that back them up. So we have folks from all over the state participating in those groups. We can do non-medical case navigation and counseling anywhere in the state. We do that over the internet. We do telehealth counseling. We're also a low barrier site, low to no barrier site, meaning that we don't charge for any of this stuff. We don't bill people's Medicaid for counseling or anything like that because we don't want to have to collect data on our people in that way. So every single thing that we do is free, and you don't even have to give us your legal name to get the help that we have if you don't want to. Advocacy work means policy work. We do it in a bunch of different ways. Again, I'm loving to talk about that with anybody who wants to. Education does definitely include our, like something like this, but our flagship training is that transcultural fluency. We also have a transgender 201. We have a pronoun and gender neutral language workshop, and we'll tailor training to any group based on what they request for sure. So hit me up if you have 5 or more people that you think would be into a training. I want to train you, and Molly will come with me or not. Either flavor that you want of that, we're happy to do it with or without the doc. So hit me up and we can make it work for you for sure. Okay, here come the 4 things, y'all. All right, this is what I spend my life talking about. The heart of our training is breaking down these 4 things. Most of us in this room, myself included, were raised to think about these 4 things in kind of a specific way that turns out to be inaccurate. Now that we're recognizing that trans and non-binary folks have always existed, we have to then recognize that our framework on these 4 things has been faulty all along. Because I am trans myself. I'm what we call a transgender man, meaning I was designated female at birth, but I've known that I was a boy since I was really, I mean, in my family, the real true story is that it was in between 1 and 2 years old that I started to say this and also fight my mom like really vehemently about what kind of clothes I would wear and toys that I would play with and stuff like that. I'm a dad myself. I have a 20-year-old kid, and my kid at 2 years old did not think about things in those terms. They weren't identifying everything in the world as a boy thing or a girl thing and having a reaction to it. So it's a very memorable thing in my family that I was really like firm on my gender, even around 2 years old. So we got to really see these things as separate things. But even with that being my story, I was raised like you, and I think of these things as being like aligned or something, right? But they're definitely not. These are 4 separate things. They come in every possible combination, and we got to really see them as the 4 different things they truly are. And we always start by talking about sex. Sex is easiest because that's what we know a lot about. So next slide. Oh no, we don't doing that. Okay, so let me go back. So sex then is physiology, right? Sex is the body. So sex, when we say biological sex, actually is a super complicated system. It's chromosomes, hormones, genitals, gonads, gametes, right? All of that taken together as one thing. But I still hear people use the phrase biological sex like a euphemism for genitals, right? But genitals are genitals, and they're just one part of biological sex. And since people's genitals don't always match their chromosomes or their gonads or their hormones, we can't use those phrases interchangeably. So what we call your genitals at birth is your designated sex. So your biological sex is maybe even more complicated than you know. Any one of us in here could have atypical chromosomes and not even be aware of it, right? So biological sex is complicated, even a little mysterious, but designated sex is what they put on your birth certificate when you were born, and it almost certainly was based on which kind of genitals you had, right? So that's your body. Your gender, what we're calling gender today, is what we mean by that word right now is that deep internal conviction that most of us have about being a man, a woman, or a non-binary person, right? And we just know it to our core. Like I said, I knew this when I was such a little kid. It's almost surprising to me when I think back on it and hear about it. But it's true for so many trans kids that we can see, and it's so true for cisgender kids that we can see that actually knowing your gender at a young age is a developmental stage. So I was right in line with other kids in that way for sure. And I've known this my whole life. Now, some people are not able to say that, and that is totally okay. Being trans or non-binary is still a stigmatized trait. A lot of kiddos don't even have access to some of this vocabulary. Think about non-binary, right? How many families right now are telling kids like, are you a boy or a girl or something else? Because that's cool too. And we have other words for it, and don't even worry about it. There's other people like that. We don't really say that, right? Even now we tell kids, are you a boy or a girl, right? We still are only giving them 2 choices when we now know that there's more than 2 choices, but we still haven't incorporated it in a way that little ones get to hear about it a lot. So I've known folks who came out at 11, 22, 75, right? People are going to come out at every stage of life, and it's valid. And the first thing we got to meet them with is sincerity. Even if you think there's something more complicated going on for that person, The only way to start is to say, thanks for telling me that. Tell me more about that. I'd love to hear more about what that's like for you, right? Then we'll be able to dive down in there and see what else is going on. But for most people, gender is pretty simple. It's known to us at a young age, and it's an internal knowledge that could not be swayed, right? Whichever one of those things you know yourself to be, there is nothing I could say to you right now that would get you to disavow it. Your gender is a key core part of the way that you see yourself. And for most people, it's an unshakable reality. Gender expression is the stuff on the outside, right? It's your clothes, hair, jewelry, makeup, speech, gait, gestures, names, right? Zoom always makes me think about that. Some of y'all don't have cameras on, but I can see your names. And even your name has given my brain an idea about what gender you are. Luckily, I'm a trans advocate, so I know to just tap those brakes and be like, somebody named Allison is not necessarily a woman or uses she pronouns, because that person could be non-binary. They could be a transgender man who's not ready to tell anybody quite yet. And I've known enough folks like that that I can even see an Allison and try to just say, hey, I'm not really sure until I hear more from that person. So we call it gender expression, but it may not be the way that you personally express your gender. Some people have an external presentation that doesn't necessarily align with that internal knowing, right? And this is even true for cis folks, because in our big training, we use pictures of like RuPaul and Harry Styles when he did that photo shoot with the gown on, you know. You can put on a dress without saying, I feel like a woman, of course. And if I say it that way, it sounds silly. But when our eyeballs see it, we think a person in a dress is a woman most of the time. So now we've got to start deconstructing that. And especially when we meet new people, we don't know if that person is trans. We don't know if they're non-binary. We don't know if they're cis. So we really and truly don't know. And we have to meet folks like that because the outside is really not enough. This is actually, y'all, why the pronouns have to be in the Zoom captions and the email signatures and the business cards. It's not political correctness. It's that actually once we recognize non-binary people, we realize there's no such thing as obvious pronouns. And it feels that way because people always guess yours right in most of our cases in here, but that doesn't make them obvious, right? You could be non-binary. I could be non-binary. That's why I put my he pronouns right out there in the caption all the time. Even if that's what you were going to say about me, it's a good reminder not to guess because we really don't know. And all of that is separate from what we call orientation, which really just homes in on who you're attracted to or not, right? Asexual, pansexual, bisexual, these are orientation words. A trans person can fall into any of those categories. They're not connected. You know, to be trans is not the same thing as to be gay, obviously, because there are cisgender gay people. But sometimes folks just get a little mixed up because of LGBT, I think, right? And this is not all one thing. There's LGB and there's T, basically. Speaking of which, go ahead. Transgender right now is used as an umbrella term to mean that your sex and your gender do not match up 100%. So going back to the previous slide, when we talk about your designated sex, your designation on your birth record, if you know on the inside that you're not what they wrote down about you that day, then you fall under what we call the trans umbrella, right? And if your two things do line up 100% right now, that's called cisgender. Not to create another binary, but there you go. We got to have vocabulary for it. It's like left-handed and right-handed. We have to have words for the dominant group that are value neutral, and that word is cisgender. I think that's the next slide, actually. No, it's not. That's weird. Why did I put them out of order like that? That's weird. Okay, let's go ahead. So the main important thing about trans is it's not medical, it's not binary. Okay, go ahead, Molly.
This is the next slide.
Oh, great. Here we go. All right.
Okay, my turn. So this, I always feel nervous about this talk and sharing it with medical people because I feel like there's a lot of things that we're going to cover that you may have thought of, you may be fully aware, you may be like practicing this way. And I really don't want any of this to come off as kind of like basic and like obvious. And I think a lot of the concepts, especially when Adrien shares them and explains in the way that he does, I feel like they are basic and they are kind of obvious, but they're so basic and so kind of obvious that we never really think about it in the way that Adrien can break it down. And so as simple as these ideas might seem, I think the complexity lies in how, what Adrien was also saying, like that our brains just assume certain things. And it's not because we're bad. It's not because we're doing it wrong. It's not because we're not woke enough. It's really a practice. And so I think making it very straightforward for us I think can help us practice this work. And what word did you use earlier today, Adrien, when you were saying like this stuff it's not inherent and it's
Not
not obvious?
intuitive,
Like,
right?
yeah,
Like
that was the
a
word.
lot of folks who care about equity are like, I'll just know how to be respectful of folks who are different from
Yeah,
me, but we really don't, y'all. We just don't. We have
right.
cultural like places that we don't easily see, right? We just don't see what we weren't acculturated to see.
Mhm.
And especially if we didn't even experience it ourselves. For me, I think about it a lot of times because I'm a white person. And so I get the experience of having people point stuff out to me that I truly did not notice that it happened.
Mhm.
And I'm like, oh, look at that, because I have a dominant trait there in terms of race. It means I just don't see what's going to hit somebody in a way that really hurts them until somebody teaches me, until somebody's patient enough to teach me, right? I have to be taught so that I can do a better job. Exactly.
Right. And that the hard part is when our brains go to that kind of the automatic, we have to, just like we learned medicine, we have to impart the learning that we are gaining, and that's not easy to do. So none of this stuff is easy, even if it seems very basic. It's like simple, but not easy. So I just want to clarify that. The next chunk of data that we want to talk about is something that Adrien and I geek out about all the time. We heart all things about trauma and stress and disconnection and how to fix it. But we think it's a really important thing to share when we're talking about gender expansive people. The chunk that I'm going to be responsible for, I want to also make clear, is 100% true for all human beings. There is no human being that is not built for connection. If we don't have other people that we feel safe with, that we feel seen by, that we feel heard by, that we feel known by and still cared for, if we don't feel like we belong, we get sick. And that makes total sense to me. That is how we have lived this long in the world. We don't have big claws or teeth or too much fur. And so what we've really needed to survive is connection. And so if we don't have that, we get in trouble. And there's multiple ways that we can experience disconnection. And for those of us who experience chronic and pervasive disconnection, then we will be sicker. And we have excellent data that's not a guess, that is just true. And so the four big chunks that I like to think about, but they are certainly not the only ones, what I call diseases of disconnection, trauma, isolation or loneliness, discrimination. And then the fourth, we'll talk about it. Stress is as a big one, but what we have a lot of data about, interestingly enough, is disconnection from ourselves. So I think probably a better way of thinking about it, there's the trauma, the loneliness, and the discrimination are separation from other people, but separation from ourselves is equally deadly for our bodies. We don't work well when we are not connected to our own needs and our own experience and existence, really. So this is probably all old hat. I hope it's old hat for folks. So the ACEs study, the Adverse Childhood Event Study, 1998. The story is fascinating if you haven't heard it, but I think of all the groups we speak with, y'all would be the ones who probably know the most about this study. I think this study was really interesting because as much as trauma is a part of our lives and suffering is part of people's lives, this was the first study that really showed the connection between adverse childhood events and adult outcomes. And interestingly enough, I have a friend who is a friend of Vincent Felitti. And when he first came out with this pretty good data, he actually got kicked out of multiple grand rounds, just laughed right out of grand rounds. Just people were offended that he would dare bring this data to them. And I think something about trauma and something about suffering in the setting of medicine is really hard for people to tolerate. And I have theories about why that is, but I won't go into that now, but it's just an interesting story. Now we talk about the ACEs, we have DOH and CDC policies about the ACEs, but when he first revealed this data, people were very resistant to it. But we know that trauma, which I like Bessel van der Kolk's definition the best, which is not being seen or heard. If we are chronically not seen or heard, and the ACEs are very nice, very discrete, very measurable, I guess, inputs that have the output that has a gradient effect. The more you have, the more likely you will have obesity, hypertension, diabetes, incarceration, physical and emotional and social I guess, vulnerabilities will be placed on your life. Luckily and thankfully, it is not 100% connection. I have an ACEs score of 6, and I'm here before you instead of all sorts of other places that I could be. So I think it's really important to understand that potential impact of trauma, and also to understand the really important plasticity of our brains and our beings, and how important connection and belonging can still offer some protection for folks that have had trauma as a child. I also think it's super interesting, and I accidentally the other day, someone who was upset that I was part of an article in support of trans people in sports actually identified me as a psychiatrist and incorporated some of you all in a horrible email about what a horrible person I was. But I did feel honored to be mistaken for a psychiatrist, because I think there's just so many things that you all know that I would like to know too. And so hopefully someday. But this group would be the group that would know the most about the different types of trauma. I think PTSD is really something also was difficult to get into the DSM. People were very resistant to that, but that's something we're now comfortable with. To me, that's like one piece of ice on an iceberg. There is chronic trauma, which is kind of ongoing. And then there's developmental, complex, or relational, kind of all the same things. And I think that's going to be what we realize is underneath the water in terms of the iceberg, because I think we're going to find this is so pervasive. What we need as babies is mirroring and attunement. And what we're finding is if we don't get enough of that, if we don't have sufficient amounts of attunement and mirroring, it affects not only our development, but really affects how our brains and nervous systems work going forward in life. And I think this is going to be something that is I am super excited about this. It's frustrating now because we don't have a ton of interventions, but I'm really excited about learning more about what we can do with developmental, complex, and relational trauma. And this is a slide I include not because it's something that you all don't know about, but because it's something that we see so much in all fields of medicine. And when folks are demonstrating kind of consistent loss of self-worth, loss of sense of self, if we, I have a really hard time with long eye contact. My husband is a connector and an eye contactor, and I can't handle it for too long. People with chronic trauma have a sense of either everything is safe because they're so dissociated, or nothing is safe. Even if they are really, really safe, their nervous systems are still very hypervigilant. And so I think thinking about these kinds of things when we're interacting with loved ones and patients and family members, thinking about kind of the identifiers of what could be developmental trauma, I think is really important for us. So in addition to the data that we have about trauma being a really big impact for our health, we also know that when we are separate from ourselves, we get very sick. So on the left, Gabor Mate is a Canadian physician, and he has many books. One of them is When the Body Says No, and that's what I'm going to focus on now. The subtitle is The Cost of Hidden Stress. I think what the subtitle should be, because what the data actually is all about, this entire book is about multiple sclerosis, ALS, melanoma, breast cancer, and the reams of data that's associated with those disorders and people who have no boundaries. I have had melanoma, so I can already tell you I struggle with boundaries. But it's not just boundaries, it's about being disconnected from ourselves and being conditioned and taught that we have no right to exert our boundaries and to say that we have needs and to say that we exist. And if we do that enough, we will get sick. And I think the data in here is terrifying. And I think he has wrote so many books that I think just kind of flip things just a little bit. It's not like we don't know that, but to see the extent of the data, I think is very impactful. His newest book is another thing that Adrien and I like to geek out about, is The Myth of Normal. And if folks have not read this book, I would highly, highly suggest The Body Keeps the Score by Bessel van der Kolk is fantastic, and The Myth of Normal. The Myth of Normal is like 2 Bibles worth of a book. So if you want to audiobook that one, it's excellent, but really helps with framing of how these processes occur, the effects that they're having. The fact that 80% of people who have autoimmune disorders are cis females is something that he has a whole chapter about. Fascinating stuff. But I think we really need to be thinking about disconnection and how much that affects our patients and ourselves. It's not a patient thing, it's a people thing. The data we have about loneliness, I'm sure y'all have heard about. The current Surgeon General and the same Surgeon General was under Obama. Vivek Murthy wrote a book called Together. And I think all of these things, and then the CDC has a website, the National Academies of Sciences has also done a really excellent study that basically shows that loneliness is as deadly as cigarette smoking. And so with all of these, when we look at all these resources and how big this problem is, it's a huge problem and it's killing us. We don't have solutions to it. So they say things like, go to your doctor, but your doctor's not going to have a screening tool for you, and your doctor's not going to have a solution for you. And so again, I think it's a public health problem, similar to how we think about cigarette smoking now. And I'm excited about kind of the future of how we're going to address these issues in the same way that we've worked with cigarette smoking. The fourth and final disease of disconnection I'll talk about is discrimination. And this is social economic exclusion intentionally based on some aspect of your identity. In 2015, the National Center for Transgender Equality came out with the US Transgender Survey. This was essentially an analysis of every institution that we have to interface with, starting with family, carceral system, employment, educational system. And really, it was stunning to me to see the level of discrimination that gender expansive folks face, that trans and non-binary folks face. The study had 28,000 respondents, all of whom were trans or non-binary. Some lowlights were in the family. 1 out of 10 was physically attacked when they came out. Almost 60% of people reported being significantly rejected by their families. The rate of bullying in school was astronomical. It essentially points out that if you are not able to be part of all of the institutions that we require to be a part of, you have very little choice about what you can do with your body and what you can do with your life, and like the choices that you have are much more limited. And unfortunately, the healthcare system did not fare any better. 20% in this report had been refused care because they were trans. And I hear stories about this all the time. I hate to believe it. And I also find it hard to believe because I work with people in medicine. I am a person in medicine, but the stories that I hear could still to this day in New Mexico at UNM that Dr. Crandall always gets to hear about are really heartbreaking and really hard to understand. In this study, 50% of folks reported having to teach their doctors how to care for them. And I think, and I'm sorry I didn't do this ordering correctly, but the first, second, and fourth bullet points, I think, are elements of structural violence. So these are things that have made people sick and have impacted their lives. And then the HIV rate being as high as it is, and the suicide attempt rate being as, it's just like nauseatingly high. Those are the health outcomes of the structural violence that folks have experienced because their identity, because they're trans or non-binary. And so when we think about the health outcomes, basically all 4 of these diseases of disconnection have huge impacts on health. And so what I think is really interesting to think about, again, this is not about people who are gender expansive. This is not something's wrong with trans folks. This is nothing about that. It's about what our culture deems normal and acceptable versus not. And then if we're not deemed normal or acceptable in our culture because of the way we are built, we will get sick because we need that connection and we need the safety of each other to survive. The cool thing about how powerful structural violence is, how powerful or structural determinants of health, if that's an easier thing to understand for you, they kind of mean the same thing, but I like the terminology of structural violence better. It's more clear to me. It's bad, it makes us sick, and we should try to stop it rather than try to work around it, which I think structural determinants of health, we have this kind of like, let's work around it. Let's try to figure out how to help people when they're experiencing structural determinants of health rather than saying, the system is broken, we need to make it a different system. The cool thing though is when we think about it, and I don't know a lot of data about this in other groups, but when we have this amazing data about what structural belonging can do for folks who are gender expansive, and it's equally powerful. And that gives me so much hope about gender expansive folks, but also for everybody else who doesn't feel connection and doesn't feel like they're part of the norm or the dominant trait groups. So the 3 things I talk about with my families when I see youth who are gender expansive is how powerful family support is, how powerful the use of pronouns and names are, and how powerful access to medications if somebody wants it, which is not always the case. But those are the 3 pieces of belonging data that we have that I think is really exciting to think about for everybody. How can we utilize this kind of data and apply it to other groups and see the same awesome benefits? So the Family Access Project is a really cool thing. It used to be at San Francisco State. I don't know if they're still housed there, but they've done a lot of work. These images on the top are LGBTQ kids. So I just want to clarify, it's not just transgender, it's all, like sexual and gender minorities in general. And you will not be surprised to hear that people who experience a lot of support from their family, self-reported support, do not engage in riskier, scary behaviors. They believe that they are special and they treat their bodies like they are special. They have been told that they are precious and they live in their bodies as if they are precious. And this is not true for all of us. I would be surprised if this data, like, of course, this data is true for all kids. So I think it's just a really important thing to think about. We just have it in the LGBTQ population. So I love getting to tell my families, good job, you're here. That is a huge step in supporting your kid now and in the future. Kids who are gender expansive are not relegated to a life of misery and discrimination at all. This is something that we can keep working on together. And I think the family is a really important place to start. Second most important thing I talk about is how important pronouns and name use is. One of your child's psychiatry fellows and I worked together when she was a medical student, and she heard this data and she was like, the medical school needs to know about this. And so she made this amazing presentation about this. And now the entire medical school trains their medical students to use their pronouns when they introduce themselves in clinical settings, because this data is so powerful. So thank you, Angelica. Good job. Still, props to you. The study actually showed that when kids were able to use their names and pronouns, their appropriate name and pronouns in just one setting of their lives, so home or school or at work or with friends, just one, their suicide attempt rate went down by 56%. And so what I like to share this data with families is to say use of names and pronouns isn't about wokeness. It's not about saying you understand it or agree with it. It's not any of those things. It is saying, I care about you enough that I would like you not to want to kill yourself. Or from a physician standpoint, I don't know you, but it's my job to care about your health. And I'm going to care about your health in this way as well, even if it doesn't make sense to me and it's hard for me to use my pronouns. I'm going to try to be a safe space for you so that your names and pronouns, my use of your names and pronouns, can be a suicide prevention rather than being a suicide exacerbator. So I think that's really powerful, really interesting data. And the third and my final slide is power of access to medications if somebody wants it. So this is something that's up for debate in a really shocking and disturbing way right now across the world, not just in this country. But the data that we have is that I have no question with the data that we have currently that access to hormone therapy and access to pubertal blockade is evidence-based and it is life-saving. I will note that in no state or country where pubertal blockade is being made illegal for children to access, there is no place where it is the same medication is not available for people with precocious puberty. They are totally allowing it for every other indication except for gender dysphoria. So it's not that they're concerned about the safety of the medication. That's not why they're making these medications not usable. They are only making them not usable for kids who have gender dysphoria. So I think that is a really clear example to me of how problematic this is. But the data that I have seen, the data that I feel safe with, the reason I do the work that I do is because the data to me is very clear. There is no major medical association in this country that does not support use of this medication, the use of pubertal blockade and gender dysphoria. So I think it kind of depends on whether or not you think evidence is important, or whether or not you think medical providers should make decisions with their patients. I think it's going to be a really interesting thing going forward, but I have no concern that the medical data and the scientific data that we have really supports this as life-saving and evidence-based. And it's cool to think about, again, like, how do we take this data about structural belonging? I see you and I hear you. I'm a parent and I see you and I hear you. I'm a doctor and I see you and I hear you. I'm going to do the things that will align your gender with your known gender. I think it's really cool not just to think about that in trans populations, but also to think about that in all the groups that we work with. What kinds of things can we be doing differently that does not promote structural violence, but instead promotes structural belonging? So if you have any ideas, let me know. I would love to hear about it. All right, Adrien.
Okay, yeah, barriers to care. Let's go.
Oh,
Is there more? Yeah.
is the slide, can you see it?
It just says
Just
barriers
go.
to
Go. Got it.
There we go. There we go. So this is from a 2020 survey, not the big trans survey, but one from Centers for American Progress. And it's shocking, I think when we train healthcare providers, people don't like to see this. I would hate this. If this was a slide that was like professional trans educators made people feel shamed 48% of the time, I'd be like, I don't like that. I don't want that to be true about me or my profession, because I'm a person who's out here trying to help people. So I know this is hard to take in, but it's really important to see what the experiences of this population are. Because the problem is sometimes it can feel like bending over backwards to make sure that they don't feel this way. And we often have people tell us that they feel like they really do treat every patient with care and respect. And you have to go further sometimes with groups that are really traumatized and feel locked out of care. And word of mouth is big in our community too. So we've built up a culture of fear around accessing care because of stories like this. So it really does mean having to say those pronouns. I know that was hard for Molly to do when she started, because we don't walk around saying I'm Molly and my pronouns are she. But now I bet she barely even thinks about it because you've been doing it so long. And this is what we're going to do in the future, is introduce ourselves with our pronouns. And just because we're on the cutting edge of it right now, it feels awkward. But 20 years from now, when that's just how people walk into the room and express themselves like that, it's going to be like, why did we feel so weird about it in the first place? Why did we not have left-handed scissors? We talk about these things being minority traits all the time. And when you look at the history of other minority traits, it goes just like this. Usually things even like being left-handed or born with red hair are stigmatized and even demonized until somehow we get to the other side of it. And it's never that population that does it, right? I always say the people with red hair did not slowly learn how to become less evil over time until we got used to them. The people with red hair were not evil ever, even when we said they were. So they weren't doing it. The rest of us were doing it. And that's what we have to adjust for here, Okay. Yeah. Right. This is really the slide I was commenting on. I'm sorry. The first one was really more financial barriers, but that's still real too. Those are still real issues that people have, even in an era where insurance pays for these things more all the time. But it's a precarious era too, around things like policies and coverage and laws. So we move forward and we move back on some of these things. Yeah, the more we can learn about any group like this, the more fluent we can be. That is why we call our training the way we do. It's Transgender Cultural Fluency. POC means people of color. Thank you so much for asking that. Okay, so how can we help? What can we do? We can understand that trans and non-binary folks have healthcare concerns that are different from cis people, and they usually fall under these headers. When I go into my provider with something that's not going to be like a cis man, it's going to fall into one of these categories usually. But if I have strep throat, it's not trans strep throat. So a lot of my healthcare is just like a cisgender man. And it's our job to help figure that out together about where am I different and where am I the same? Because we definitely don't want to be treating somebody as different if it's actually a place where they're the same. Even lab results can be, we have to keep decoding these things. Most of my lab results should be compared to other men, but I helped with a case study for some med students at UNM, and they had this case where a guy came in needing to be cleared to go back to work, and what he had to do to get cleared was a respiratory capacity test. And he kept failing over and over and over, and they didn't understand what was wrong because he seemed like he was better. And then finally he said, "I'm transgender, does that matter?" And they were like, "Oh, wow, yes." Because on that test, like my lungs, my heart are never going to get bigger as a trans man than they were when I started testosterone and all of that, right? So some things like that, he was cleared for work that day and he could have been cleared weeks earlier, but he didn't know that he needed to tell them that, and they really didn't ask him, which is more important, right? Shouldn't have been his job to have to figure out to fess up about it or whatever. Should have been something in an intake on an EMR where we already knew that and we're already screening in the appropriate way. But we've also had a lot of stories in our communities of people, we call it actually trans broken arm syndrome, because people will go into a care environment with something like a broken arm, and the first thing the provider says is, let's stop your hormones for a little while to see if that's part of it. And then we want to just run out. So important to just think about the fact that, there's so many places where I just have to be treated just like anybody else. And of course, there are also things that are going to be special about me, which is true about any patient population.
And I'll just interject super quick here. I think this comes up a lot when people are engaged in care. I think particularly when folks go to the emergency room, people assume that when they find out that someone's on hormone therapy, whether it be masculinizing or feminizing, that it's because of that. I think an easier way of thinking about these medications and thinking about the hormone therapy, especially for psychiatrists, is that if you are worried about something in a cis male, if you would not prescribe a medication to a cis male or a cis female, then you should think about that medication in setting of someone on hormone therapy. If you would never consider it to be problematic in a cis male or a cis female, it's probably not going to be problematic in somebody on hormone therapy. Really, what we're doing is shifting the predominant milieu of the sex hormones. So we all make testosterone and estrogen to some extent. What we're doing is using bioidentical hormones to shift to match someone's gender, but it's very infrequent that it's causing a problem, and it's almost never true that it would be contraindicated with a different medication.
Right on. We feel like if these 7 things were really thoroughly addressed and considered, then a healthcare environment would automatically be more trans inclusive. So it's not like you have to have a perfect answer to all of this. We know that some buildings have bathrooms that are gendered with multiple stalls and urinals and stuff like that. We're not saying we have to rebuild the building or rebuild the bathroom, but you can easily hang really reassuring signage in your bathroom that lets people know that they are safe in the bathroom that they choose to go into. And even for me, who is never thought to be in the wrong bathroom, which I'm not, but I'm not mistaken for being in the wrong bathroom as a trans person, right? So I don't even have that problem anymore. I did before I transitioned. I lived for 20 years as what we used to call a butch lesbian because I never heard of anybody like me and I didn't know there were people like me. And so for a long time, I appeared to be a butch lesbian and thought of myself that way. And people always told me I couldn't use the bathroom then. But now folks don't bother me in the bathroom. And even still, when I see signs like that, I feel calmed and comforted knowing that if something weird happens in there, I'm not just going to get automatically blamed for it because I was the person who was different and I was in the bathroom. So it's not like you have to rebuild. You can just make a more inclusive culture. Note taking, right? Oh, so let me go back 1 second. Sometimes y'all are going to have to use what we call somebody's dead name, their legal name that is not the name that they use for their notes. And sometimes their gender that's not right, their designated sex rather than their gender, because insurance often won't reimburse if your notes don't align with what's on the documents, right? But if you're going to write up a note about somebody using their dead name, you really have to tell them that before they leave the office. So I'm not saying that you always can keep the records in the optimal way, but if you have to have mismatched records, you got to communicate it to the patient because we go out and log into our portal. And if I log into my portal and see you calling me by a name that I don't use or referring to me with an F, I will maybe never come back there again. So you just got to let me know why you're doing it. And actually, that's a great opportunity to refer somebody to TGRC for help with their name change anyway. Okay. Yeah, I love diagrams like that, right? If we're going to talk, I mean, I know psychiatry maybe not as much, but if we're going to talk about symptoms, exams, procedures, we don't have to have sex organs on those things, you know? We can just draw them on or circle that area or talk about it even, but it's nice to think about accommodations that we could make for people. Okay, where are
I'm
we?
so sorry, but I am doing a horrible job governing the
That was
slides.
like the Blair
So
Witch
sorry.
Project. Okay.
I was possessed and it was me.
Okay, what's after this? Here we go. Okay, yeah. Yeah, I think we've already said this, you know, but it is really important to say your pronouns when you meet new patients. And the issue here is that you can't stop doing it just because somebody's older or just because they look really stereotypically masculine or feminine, because that still doesn't tell you what's going on with their gender, y'all. So people sometimes will do this only if somebody's a little gender variant, you know, and we really just have to make it our practice. When we do our in-person trainings, we bring these really beautiful enamel lapel pins with your pronouns on them. And we say, put them on. If you walk into a room with your pronouns on your clothing, a trans person will breathe a sigh of relief when they see that for sure. Pronouns are not the be all end all of supporting trans people, but it is a really, really great place to start. Exactly. We got to
I
ask.
know that Cam can give you some pronoun pins too if you want them.
Oh, good. Yeah. Y'all have them over at UNMH. If you've met one trans person, you've met one trans person. Every single trans person's on an individual journey. Some people do not experience dysphoria at all. And even with those of us who do experience dysphoria, we all want different treatments to be able to be fully healed, right? So it's really important to remember, like, you can't even start with something that seems on the surface supportive, like saying, hey, when do you want to start hormones, right? That might, for me, that a doctor had said that to me, I would have started weeping with joy. But for some people who don't want to take hormones, now they don't know where they stand with you. And they think maybe that person thinks I'm only really a woman if I take hormones, or I'm only really trans if I take hormones, right? So it's got to be really open-ended stuff. It's got to be recognizing that each person is going to be so different from each other. Go ahead. Yeah. So just even knowing that, yeah, people, we use the word transgender in that umbrella way that I told you earlier. So to me, that word includes all non-binary people. But I know non-binary people who do not put trans on their name tag, right? On their sticky name tag. They only use the word non-binary or genderqueer or agender or whatever it is. So you got to hear it from them. And we have to have a way that we use the adjective transgender in the language. And then we have to also recognize that everyone's putting a name tag on, and that the most important thing in an individual interaction is that person's label that they use, right? I like to use they as a default. When I don't know people, I use the singular they to talk about them because it gives me better practice doing it. And it reminds me not to think I know that person's gender, right? We're going to make mistakes. It's important to quickly, briefly, sincerely apologize like this. Rachel, I'm so sorry. I know that your name is Rachel. I did not even mean to say that. I'll do better. And then get back to whatever you were talking about. Keep it moving, but make sure that she hears that you heard it. Okay. Yeah. And like taking the workshop on the gender neutral language, even reading things online about gender neutral language, it's really helpful because most of us weren't raised like that. So we're changing our language right now, which always feels a little awkward and a little constructed. So the more we can practice, the more we can learn. How do we call people in the waiting room? Do you ever use people first names? I would not do that probably, because the legal first name that you have on their record may not be something that they want called out in the waiting room. I have never understood why doctors' offices don't use like deli numbers. Isn't that a HIPAA thing, calling out people's names? Why are you yelling out people's names in the thing where everybody can hear the name, but we have all this HIPAA? You can't even have closed captions, Molly, because of the HIPAA. And then someone walks out in the waiting room and says your name right out loud. So I don't know. I would think about that, honestly. I'm sure numbers feel impersonal, but a lot of people would probably appreciate the privacy, you know? Some folks do use different words for their body parts. It's just good to keep it open for that conversation. In all of her years, Molly says she's never had someone ask her to call it something interesting or fun, but you never know, and people do, and you just got to keep it in mind. Because for trans people, we may not relate to our body parts in the same way that you use the words for them, right? Go ahead. These are actually directly from Presbyterian's EMR, Epic EMR. The way that Pres has adjusted their EMR to work is to ask these questions. An organ inventory, y'all. That's what they call it. And they ask your designated sex, your gender, your chosen name, your pronouns, and your orientation to capture all that information in case it matters. Okay. Yes, right. Where's Gabber? That should be Gabber's picture right there. The picture of his book should be right there. The reason we That's exactly it, right? We do all that talk about stress-related illness, just like she said, because trans people grow up with a whole lot more of a stress load from being so different and for not being understood. So it creates that not being seen and heard child trauma that Van der Kolk defines that way almost universally in our population. It's really hard for a trans kid to get anybody to validate that very core thing about them, which is their gender. So you start out in life with a lot of this. That's why I think we see a lot of substance misuse, anxiety, depression. The suicidal behavior is completely off the charts. Non-suicidal self-injury off the charts with teens in our state that we've measured. So it's bad, but it's not because people are trans, right? It's because of the way people are reacting to trans people right now. Go ahead. Yeah, all of it is slow and it takes time. I always hope people will think of any training that we do as a first step instead of a last step, so that we can keep learning about all of this and keep getting better and better at it. This is going to let trans people have much more safety and much more access to care as we keep learning together. Right. Those are from a book called The Body Is Not an Apology. And I know I'm working on those 3 things every day, y'all. Sometimes for me, it's really hard to feel like I don't understand, but I just have to keep coming back to the fact that, like, I'll never understand what it's like to be non-binary any more than I can understand what it's like to be autistic or Native American. And I have a lot of friends who are both of those things, and I can't ever walk in their shoes, but I can still understand that their shoes are real and that they're having a journey in them, and we can walk with each other, you know? Sometimes I want to know so badly, but that's not always what it's about. All right. Yeah, here we go. This is the perfect place for some Q&A if y'all have it. Look how we did that. We rolled right in at 10 till.
And as folks are formulating questions, I'll just show just some QR codes. One is for TGRCNM. This is the biggest, most comprehensive resource center for trans folks in the country. It's like very well known across the country. And I think this is the TGRCNM is a big reason why we are the strongest refuge state actually in the country for LGBTQI. And I think that has a lot to do with the work that Adrien and his group does. And then the other QR code I wanted to add is that we have a gender care echo that happens every 2nd and 4th Thursdays from 12 to 1. If you click on that QR code, you can sign up for just calendar invites. You're not committing yourself to anything, but at least you'll have some calendar invites and some connections to that.
Yes, we would love to. We would love to. Thanks, y'all. We see you in the chat. A lot of thanking us, Molly. It's really great.
Adrien, I have a quick
Hi,
question.
oh, sorry. Someone else might be before me.
Go ahead, Mars. I'll go after you.
Okay. I'm Mars. I'm a 2nd-year psychiatry resident. I have a question, not about the presentation, to be honest. So on TGRC website, there are like a bunch of listed groups. I'm sure it's like connection group versus like, is it a counseling group? And then I want to know, are they on Zoom or are they only in person at TGRC?
Wonderful. Yes, we have 8 active support groups right now, and our groups are peer-led groups. So they're not counselor supported, they're just peers helping peers. They're 8 specific stratified categories, but you're welcome to attend more than one group if you fall into more than one category. It's not meant to force people into a binary or something. It's just over the years, these are the groups we were asked for. And so we just let them be formed in response to the requests, right? And each group is backed up by a Google group. So when you register, you're added to a Google group where people email and things all month long outside of the meeting times. And at least 3 of our groups right now have really strong Discord servers as well, especially the youth group. So they talk all the time. And then each group meets once a month in person here in Albuquerque and once a month on Zoom. So and then we do have also a counselor on staff. He doesn't run our groups, but he's also trans. And he does in-person appointments at our drop-in center when we're open on Monday, Wednesday, Friday, but telehealth on Tuesdays and Thursdays. And every one of our services is free, completely free. We don't charge or collect data. So if folks don't have insurance, especially, or if they need help like that, then they should reach out. We have a remote request for support form on the website. So you can go to that form and ask for a whole bunch of different kinds of help with that one form. And the support groups have their own section on the site with each registration link there. Thank you so much for asking that. Was it Jason?
Yeah, I have a quick question for you. This was a great talk. Thank you so much. I work in addiction medicine, and there are several different guidelines from different organizations that talk about drinking levels, safe amount of drinking, and risk levels. Every single one of them says male or female. And so I'm presenting these documents often in lectures to students and residents. And I'm worried every single time. I did this yesterday and I was worried that I'm saying this incorrectly. And so I just kind of want to nail it down right now, exactly how to say this. So I think it should be assigned sex at birth males and assigned sex at birth females. Is that correct?
Well, I take issue with those kinds of classifications a lot of times, you know? I would love to see the research that caused it to be that way in the first place, because I think often we're talking about body size, body type, body weight, you know? And one of the
Well,
things that
and
upsets me,
I think liver size and function.
is that what it is?
Yeah,
Okay,
but really, it's more the terminology I'm curious about. I just sort of am always worried I'm saying this slightly wrong every time, and I want to try to get rid of
okay.
that.
So if we're gonna just, sorry, I didn't mean to get esoteric about the categories, but that's my jam, right? So I would say designated male at birth and designated female at birth. And if people say, I don't really know what that means, then you can say, what was on your birth certificate? M or F, you know? And then you can route them the right way.
Thank you.
Yeah, totally. Sorry.
And I love
Answer.
that you're thinking about that though, because like this is why Adrien and I are friends, because we want to go deep. We don't want to do the answer the question. We just want to think about stuff. But I love that you're thinking about that, because it might be more words and a bit like more blah, 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 like clumsy to come out of your mouth. But I feel like the more times that we can indicate that there are more than cis male and cis female, the more that we can open up the construct of gender for everybody that we're talking to, not just learners, not just patients, but each other and ourselves. I think it's really, really helpful, and it just helps with that practice of kind of expansion, I think, and recognition and including in a real way, not a checkboxy way. So I love that you're thinking about that. The other question, Adrien, that might be linked in the to Jason's question is in chat, and it looks like Lydia is wonderfully answering that, about Spanish pronouns in terms of non-binary and how tough it is, because I mean, just with the very gendered language.
And if you've met one trans person, you have met one trans person, right? Because non-binary people also still use he and she. So it's not, we don't know someone's pronouns, even if we know they're non-binary or trans, right? That's the really like complex part of it. But, and furthermore, in the Spanish speaking world, some people are loving some of these options that are being listed in the chat right now, and other people are taking real issue with it. Like it's a big old dialogue and debate among Spanish speakers about how to be inclusive right now in a language that is so hardcore gendered, right? It's so binary, and every single word is either male or female, masculine or feminine. So it's evolving. It's evolving just like the language that we're using in the US is evolving all the time. So just ask folks, ask them what they like, ask them what pronouns they want to use. Tell them yours. That's always the best way to start. If you say, hey, I'm Adrien, I use he pronouns, that cues somebody to give their pronouns back to you. And if they don't, then you can say, oh, Molly, it's great to meet you. What pronouns do you use? Because I already said mine, right? I made it part of the introduction. So then to ask for it isn't essentially saying you look weird to me. I don't know what to call you, right? So you say your pronouns, they'll probably say theirs. And if they don't, you can just ask them at that point. Fantastic questions. Some other good stuff in the chat I saw too.
I have a question, if you can make any relatively quick comments about how can we as healthcare providers support families of those with trans or non-binary people in their families, and the family members are struggling with perhaps ambivalence or not knowing how to support their family members. How can we as healthcare providers support those family members? Do you have any sort of guidelines for us?
Tell them, Molly.
I was waiting for you to answer.
You tell them, you tell them.
I think the reason I was reticent to answer is because I don't know, there aren't clear guidelines, and it makes it really hard. I think the most important thing that I don't get graded on, no one's giving me feedback on this, so I don't know if it's effective or not, but I think it's really valuable to do what you are already naturally doing in your clinic work, which is to give space for everybody to be heard and to have feelings and emotions. What I like to do in my clinic, I like when, especially for that first visit, is really honor parents' concerns, questions, like challenges. Are family members struggling with pronouns and names? Here's this great data that you can share with them. How are you feeling? Are you grieving? It's understandable to grieve. You don't get to do that with your kid. Like that you like, so I try to honor their, like they are having their own experience, and I value that. And I want that space to be a space where that's welcome. But I also want to make clear that that boundary is you don't put that on your kid. And then I also like to make space for the patient in my mind, one of the medical interventions is that this family is doing this together. And so if there is contention, if they are not aligned yet, if the parents are still just like, I care about my kid, I just don't know what to do, then I will slow everything down so that we can try to be in the same space together. And I have worked with families for like 2 years before they feel comfortable getting their kid on hormone therapy. And that's not even the goal. The goal is for the family to be aligned and to be able to hear each other. And so it's not just that I'm trying, like, I want that kid to have that support from their family because I see how powerful that can be for health. And I feel like honoring everybody's experiences, but also protecting, like, a lot of times the kids want to be on hormone therapy right now, and they've been thinking about it for a long time. They know all of the like perfect language, like I want body fat redistribution and like all this like high tech language, and it's so beautiful. And then their parents like, yeah, they're not going to be able to get on hormones until they're 16, and you're going to see this like total loss of hope and sadness, and they shut down a lot. I see a lot of kids that get shut down. And so, and even with parents that are really trying their best and doing everything that they can. So I try to also see that and say, hey, it's like, that's really disappointing for you to hear. Like, these are all the things that you could teach me all of how to do better. But I think big picture, there's no specific guidelines, but just creating a space where it's safe for everybody to have emotions and also be really clear about boundaries so that those emotions aren't getting put on the kid.
If there is any way to get them to our peer parent group too, they are the sweetest people. And they're really about normalizing the fact that you might be grieving and it's okay. And let's work it out in the parents group, just like Molly said, not with your child, right? And these other parents, some of them have been right where you are. And so it's really okay to let your guard down and just say, I hate this. I don't want this. I don't like this. I wish my child was just cis, or whatever feelings you're having can get put out there so that you can move through it and go back to the child, right? We're always trying to get the parents to turn back to the child. So that peer support group to me is a really safe and sweet place to like process and get help and get support and then get real answers and referrals and information for sure. So if you think they might have the inkling of going to something like that, try to get them to go do it. Try to get them to go do it.
And I love Dr. Mantrek was named we don't know each other. And so it was a great way for us to meet. Thank you for being so kind about that. The question that you've offered in the chat is folks have felt unsafe accessing psychiatric emergency services. What is a good way to prepare patients to access these services when needed? And I would kind of flip that. I would say, I think really the work is on our end, that we need to make spaces actually more safe, because it's not just that they're hearing it and it's fake, it's that they're hearing it and they're experiencing it because it's real. And so I think the good work that we are doing here today, that you've invited us, that y'all are curious about this, that you're asking these questions, is really a really important part of that, because they really aren't safe. They really aren't safe going to the emergency room. They're really not safe going to psychiatric emergency services. And I think until the medical system really does an evaluation about how to create more structural belonging specifically for gender expansive folks, it's going to continue to feel that way. Because it's not up to me to tell a patient that they should bypass their fear and bypass their stress about going like that. It's a hard conversation to have, and I will do everything I can to support. And so you all will too, and you do too, but I think that's a structural thing. And so even the front desk folks and the custodial staff and like anyone that they're going to interface with may have to have trainings like this so that the space that we are working in actually is safe for folks to access. It's a great question.
And some of these kids are going to get put in that place without getting to choose to go or not. So to me, are you able to be an advocate for them? Can you find someone who will? Is there anybody who they will know is sticking up for that kid from the outside and holding people accountable? Like, not in a horrible way, just like a little accountability around, are we using the pronouns and how are you doing, kid? And being able to advocate and be a liaison. If there's someone on your team that's available to do that, if not, maybe we could help it in that way. Just let's get together around a kid like that so that they don't just go in there and get swallowed up.
Awesome. Really, really important stuff. Great information and education. I really appreciate both of you, Adrien and Molly. Thank you for your time, for your expertise, for the resources that you provided and offered. And I hope this is the first of many conversations to come. So thank you again, and everybody have a good Friday. Take care. I think we'll go ahead and wrap up there.